Good afternoon, everybody, and welcome to this joint SHOT and National Comparative Audit webinar. The webinar will involve a 40 to 45-minute presentation, followed by an interactive Q&A session, and then a feedback poll at the end. This webinar will be recorded and will be available to watch on the SHOT website soon after the session. Your microphone will stay muted throughout, and there isn't a chat function this time, but we'd still love to hear from you. Please pop any questions you may have into the Q&A box, and we'll do our best to answer them either during the webinar or in the Q&A session after the presentations. If we don't manage to get to your question during the webinar, please email us at shot@nhsbt.nhs.uk, and we will endeavour to respond to you. Without delay, it gives me great pleasure to introduce our speakers to you today. They are as follows. We've been joined by the National Comparative Audit team, and there's Dr. Catherine Booth, who's the clinical lead of the National Comparative Audit of Blood Transfusion, Associate Medical Director for the RCI and Genomics, Consultant Hematologist in HSBT and Barts Health NHS Trust, and a member of the SHOT Steering Group and Working Expert Group. We're also joined by John Grant Casey, who's the Program Manager for the National Comparative Audit of Blood Transfusion at NHS Blood and Transplant, and Paul Davies, who's the Senior Clinical Audit Facilitator, National Comparative Audit of Blood Transfusion, NHS and Blood Transplant. And a very good welcome to Graham Donald, who's a lay member representative of the SHOT Steering Group, National Blood Transfusion Committee, and the National Comparative Audit. We are also joined and supported by various members of the SHOT team. Just to provide an overall of the session for today, we will start with an overview of the National Comparative Audit of Blood Transfusion. We will then move on to learning cases from the recent annual SHOT report, which are relevant to the audits being discussed in today's session. We'll be sharing insights from 3 recent national comparative audits. We'll be signposting any useful resources and next steps, and then we will move on to the Q&A session. So please, if you have any questions throughout the webinar, please do pop them in the box. The audit reports being discussed today will cover the audit of NICE Quality Standard QS 138. We will also be looking at bedside transfusion practice, and we will close with an audit on major hemorrhage protocol audit. I'm now going to be handing over to John Grant Casey from the National Comparative Audit team, who will be providing an overview of that. Thank you, John.
Thank you very much indeed. And good afternoon, ladies and gentlemen. Welcome to this SHOT webinar. So as you heard, I'm John Grant Casey, National Comparative Audit Programme Manager. And this is just to tell you a little bit about what that programme is about. And as you can see from this slide, we started this programme about 25 years ago. And we tend to offer 2 or 3 audits nationally to all NHS and independent hospitals, and including in the United Kingdom, that is, and including also, where appropriate, sometimes to hospitals abroad. For example, we audited in Europe, and we also audit too in Australia and New Zealand. Now, for those that are not quite sure, clinical audit is about looking at the practice to see that healthcare is being delivered in the way that we would like it to be delivered. What do we want our healthcare professionals to do? So that's what we look at in the NCA. And unlike other national audits that occur in the UK, ours is funded solely by NHS Blood and Transplant. And if we move on to the next slide, please. Then we can see that when it comes to auditing transfusion, the programme that we have is given a steer by our steering group, which consists of medical royal colleges, societies and associations in the UK. We're joined on this steering group by our colleagues in the Northern Ireland Blood Transfusion Service, the Scottish National Blood Transfusion Service and the Welsh Blood Service. So we have a very good insight into what currently is our issues that need to be audited within the NHS. We used to audit back in the days things to do with how well are we using components, but now we've moved into auditing more to do with patient blood management of patients in different clinical specialities. Our challenge is that practice will vary from hospital to hospital. When you do a national audit, you're not just looking, of course, at 1 or 2. You're looking, in our cases, at up to 375 different hospitals in the UK. And that'll be different. Their performance will be different because of the way they're configured, the way they're funded, and the way they used to do things. What also affects variation in practice is individual clinical practice and the freedom that doctors have, because although there are guidelines, they only can operate those guidelines if they believe it's in their patient's interest. So auditing transfusion is covered there. And if we go to the next slide, you'll see that we also want to influence change. And we do that because what we're going to do here is to contribute to guidelines. And over a quarter of a century, we've contributed to British Committee for Standards in Haematology, as it was now, British Society of Haematology guidelines, but not only guidelines in the UK, but also guidelines around the world. And that's what makes this such an exciting job to do, because we really do influence global practice this way. So apart from the guidelines, we're very lucky to be invited to speak at national and international conferences, which is again a way in which we can influence practice outside the UK. And because we publish in high impact journals, peer-reviewed journals, we can present arguments for change. So there are lots of ways we can influence the training of doctors, nurses and scientists. But as you'll see later on in this webinar, ladies and gentlemen, that's all very well because we influence, as it were, policy and practice at a high level. What we need to do is now be able to influence what goes on in your hospitals. If you want to find out more, there are my details. You see my name, there's the mobile phone number, there's the email address. You're most welcome to contact me if you're interested. And that brings me to the end of the summary about what the NCA is about.
Thanks very much, John, and thanks to everybody for joining us today. And actually, this is a unique day and a great week to have this educational session. As people may be aware, this week we are actually celebrating the National Pathology Week. We're also having the Patient Blood Management Awareness Week, and many of you may have attended the session this morning. And also we have the Med Safety Week as well. And therefore, this is a phenomenal opportunity for us to actually host this educational event in collaboration with the National Comparative Audit team. And that resonates across several safety as well as quality teams. And I just wanted to actually briefly touch upon the critical role that hemovigilance plays in supporting the National Comparative Audit of blood transfusion, because what we then help to provide is identify those gaps in practices and the risks which are identified in all the reports that are submitted to us and summarized in the serial annual short reports. But they also then help inform. This is one of the sources of information, as John has actually kindly pointed out, that they can help identify the topics for national comparative audits. And with that, both with the SHOT safety standards and what used to be the recommendations in the previous reports and recommendations in the audits, then there would be some improvement actions that are implemented in the hospitals. But with ongoing hemovigilance activities, we are then able to monitor the trends in the reports that are received at SHOT. And that, again, that cycle continues of informing the future audits as well as the improvement actions. Now, all of you would also be actually familiar that we have now recently introduced the SHOT transfusion safety standards. And this is primarily to promote safe, effective transfusions by identifying risks, but also implementing proactive strategies. Now, these are grounded in national guidance, regulatory standards, and also insights from the SHOT reports, and they support better patient outcomes, staff well-being, and system-wide safety. Now, here is a QR code that is actually then provided for that. But I would also actually want to say that audits do figure throughout the standards for a reason. And this is actually to understand that participating in these audits drives improvement, and every audit is an opportunity to actually then engage, to learn, and to raise the bar for transfusion safety. Now, I've just highlighted the different sections where we have mentioned audit in the SHOT transfusion safety standards. Now, over the next few slides, I'll just be covering key highlights from some of the learning cases from SHOT. And a big thanks to Vera and Nikki from the SHOT team for providing the learning cases. And these are relevant to the audits that are being discussed. One is about an avoidable transfusion, another one which had patient identification errors resulting in a wrong component being transfused, and another one is a transfusion delay in a major hemorrhage situation. And at the outset, we would like to actually acknowledge the contributions of our hemovigilance reporters. Also, that the cases are anonymized, and these are based on that information that is provided, and they're representative of the data that is actually supplied. And here we are sharing it mainly for educational purposes and for embedding that learning across the wider system. Now, this is a case of avoidable platelet transfusion. This was a patient with myeloma who was admitted unwell and had a platelet count of 11 times 10 to the power of 9 per liter. And they gave appropriately 1 dose of the platelets. And the consultant who was overseeing the care documented a plan and then said that only if the platelet count was less than 20 did the patient need an additional transfusion. Now, there was a locum resident doctor who then misread it, the 20 as 70. And then even though the patient's platelet count was 45 and the patient was not bleeding, the patient then received another platelet dose. And also, it was noted that the patient was on the medical admissions unit, not the hematology ward where they usually were receiving the care. This was also actually during an industrial action, and that contributed to the system pressures. And as with any kind of an incident that is reported to SHOT, now we do see these various contributory factors. There was clearly an error in the decision making, not questioning why we are actually having such a high target. Maybe there were knowledge gaps, but also actually patient being managed on a unfamiliar environment and with various system pressures, as we actually highlighted. Now, while the improvement actions should be actually then addressing all of these causal and contributory factors that were identified, it's also important to actually then emphasize the importance of empowering patients through education. Now, that is one of our safeguards for ensuring safe transfusion. An informed patient becoming an active partner in preventing errors. And here is the QR code for the information page on our website that directs you to several resources. And also, you may already be familiar with the My Transfusion app, which has been co-produced with several patient representatives. Here are the QR codes, but there is also a browser version available. Now, another case was about an ABO incompatible blood component being transfused, and this is actually due to suboptimal safety checks. So what happened in this case? Now, there was an elderly male patient with a history of Alzheimer's dementia, was brought in by ambulance following a fall. And the patient 1, who was O positive, was transfused 1 unit of red cell intended actually for the patient in the next bed, and who was A positive. Now, what happened during that stepwise steps in the process? The unit of red cells had been collected correctly, but it had been checked in the treatment room by the nurse along with an agency nurse using a compatibility slip. So this was not being done by the patient's side. They then checked without actually the paperwork. They then checked the wristband identification. So everything was actually then done in not according to what is actually recommended practice. And then the red cell unit was handed over to the agency nurse to actually transfuse. Again, there, prior to putting up the blood, the patient's ID was actually not checked and the unit was commenced. And the patient began to feel unwell within 30 minutes with tachycardia, vomiting, and promptly, anyway, the staff recognized that this could be a reaction. Transfusion was stopped, and the acute care team were briefed, and the clinician was informed. And thankfully, the patient was then monitored, made a full recovery as well. So as you can see, again, in this case, there were several contributory factors, but primarily you can actually see how there were suboptimal safety checks, not done by the patient side, done in a treatment room, insufficient substantive staff. So you're having the agency staff who really did not have much transfusion training, and the policy, which was actually then complicated, and there was ambiguity about how the checks needed to be actually done, and delegation of the task, and insufficient skill mix. And so you can see there were all these contributory factors that also need to be actually then addressed to prevent this from actually happening again and to learn from this incident. Now, there are several resources available within the transfusion community, so both from SHOT as well as other resources. Here we have the Safe Transfusion Checklist, which was also through the CMO letter in 2017 that every hospital needed to have that. We have several resources hosted on the National Blood Transfusion Training Hub and the e-learning for health that people may be familiar with. There are several videos, short animated videos that actually then enhance that communication. There are also the cumulative data pages if you need to actually look at what has been the trend in the incidents reported and all the related resources. And we do have the access to the different chapters as well. And the last case that I wanted to actually highlight is about, in a patient with a major hemorrhage resulting in transfusion delays. So what happened in this case? There was active bleeding that was identified in a post-operative patient out of hours, and a unit of red cells was prescribed. But what happened was the urgency of the bleed was actually not communicated across the teams, and the major hemorrhage protocol therefore was not activated. And the initial sample that had been actually sent was rejected. There were no clinical details on the form, and again there was miscommunication. The lab staff were not aware of the urgency of the requirement. And in addition, we see that the clinical team on the ward were unfamiliar with the management of a patient with major bleeding. They did not know how to access emergency blood components, nor to actually activate. And unfortunately, it was 3 hours after the active bleeding had actually been identified and the patient suffered a cardiac arrest and died. So this was, the patient did not receive a blood transfusion. Now, again, in this, you can actually really identify that active bleeding, although they identified it, but was not followed up with the appropriate actions, the urgency not being, so there were communication issues, which is very commonly highlighted. Again, no record if the blood in the remote fridge was actually discussed, and staff were really not familiar with accessing that blood. There was poor documentation of what happened in those 3 hours as well. Again, this, as is usual with the emergencies, it happened out of hours with low staffing levels. There was reports of a doctor who was managing 3 different disciplines. So you had the staffing issues, staff knowledge issues, communication issues, which were all contributing to this. Now, as you may be aware, we released a safety alert back in 2022. We yet to see a tangible decrease in fact, the trend is actually increase in the number of the delays, including the deaths. But I would urge you all to actually access the resources on our cumulative data page, as well as go back to the recommended actions in the alert. But what we also realized is actually a couple of years down the line that there has to be more resources provided, although these are included in the guidance. So I'm really pleased. These 2 slides are courtesy of Joe McCulloch, who is also a member of the SHOT steering group. So along with members of the SHOT team and members across the UK, they have come together to actually then produce a concessionary release toolkit. And what it includes, now we are about to release this in the next couple of weeks, so please watch this space. This would be available in the SHOT website. So that has a one-page aid memoir for adults, the similar one for neonates and infants, as well as there is a concessionary release form and concessionary release examples. And similarly, we've also actually then been working on a major hemorrhage simulation toolkit, which would again be supporting all the staff within the transfusion community, because this was actually one of the recommendations as well in the National Patient Safety Alert. And in this, there is a guidance document. There are different simulation scenarios, also how to set up, the fake patient guidance document so that people are all familiar in all parts of that pathway. There are debriefing tools that are actually then also being provided, and blood bag resources. So we are hoping that we would be able to actually release both of these, concessionary release and the major hemorrhage simulation toolkit later this month. So with that, I'll pass you on to John, who will cover the NICE QS138 audit. Thank you.
Thank you very much. I'm afraid you've got me back again. What I said earlier on is one of the things we do in the audit program is to look at guidelines. And so the 2024 NICE QS138 audit is an example of a guideline. If you go to the next slide, please. You'll see that this guideline was first published in 2016. So that's getting on now for 10 years, 9 years. It contains 4 quality statements plus one that we added. You might be familiar with these. Basically, it's if patients have got known iron deficiency, please treat them with iron prior to coming in for particularly surgery. If they're having surgery with minimal expected blood loss, say 500 mils, then give them tranexamic acid. Also, people should be given a clinical examination and have a repeat HB after each transfusion, unless they're on a chronic transfusion program, and there are other exceptions. And people should be given written and verbal information. Now, those are the 4 statements. Our additional one was about having a good reason for transfusing somebody with a hemoglobin of over 70. So we've done this over a number of years, and in 2024 we analysed data from 5,055 sets of patients from 169 sites. So I said to you earlier on how we tend to cover the UK and sometimes internationally as well. In our program, we're very fortunate. We have very, very large data sets. And these are the results looking at 2021, 23, 24. The arrows here on the right indicating whether there's been an improvement or not. And as you can see, bear in mind this is a nice guideline supported to some degree by what the reports of the infected blood inquiry said. We've got 66% 2024 people with known iron deficiency being given iron supplementations. 2 out of 3 of those patients are given iron, 1 in 3 is not. It's a lot of iron not given to a lot of patients. If we look at tranexamic acid, we can see it's 1 in 4 patients not given TXA when it might be appropriate to do so. Again, about 1 in 3 with this business of a clear clinical reassessment. And then we have probably 1 out of 3 giving written and verbal information, and not doing too badly in terms of what we put in. Now, if you look at those figures in 2024, go back then, look at 23, 21, not a great significant impact improvement on that. Now, let me give you a caveat here about clinical audit. Clinical audit is sometimes only as good as the record that we keep. So this table, although suggests that not a lot is being done, these people could be getting iron and TXA and having the checks and having the written and verbal communications, but we simply don't record it. If it's not in the record, we can't demonstrate it's done. So if you have a problem in your hospital or your trust with this kind of performance, ask yourself if it's really, really important that we should prove it's done. Infected blood inquiry will say to you, yes, it is important. So it's not necessarily that the performance is bad, but it's just that we don't necessarily have the record. So we'll continue to do this. We're doing it now in a shortened period. Thank you for those who are taking part in that. And we'll consider how we do that in the future. So if we move on to the next slide, please. I think we can introduce my colleague, Paul Davies, who will tell you something about what we're doing with the audit of bedside transfusion. Mr. Davies.
Thank you, John. So obviously we've already seen an example in that learning case of how important it is that patients are correctly identified for blood transfusion, how important it is that they're monitored as part of that process. And obviously I think that example really leads into why we did this audit. The idea of this particular audit was to look at the BSH guidelines for the bedside transfusion process. So we're very much looking at the process of the patient, as we say, being identified correctly and the patient actually being checked correctly as part of the process. What we wanted to do this time round was to look at those BSH guidelines, see whether or not they've been followed. This is an audit we've done previously back in 2011, so we're looking to do some comparison with that previous cycle audit to see whether or not there's been any kind of improvement there. But what we were also trying to do in this particular case is understand what the reasons are for non-compliance. So where John just spoke to you and said, obviously, the issue we have is with terms of stuff being recorded. A lot of the time, that means that when we do a basic case note audit, we're not able to identify those things. So what we did differently this time round is that we did the audit as a live intervention process to try and look at what the process was as the actual bedside transfusion was going along. I'll talk about what we found from that as well. As with all our national audits, as John said, we invited everyone in England, Scotland, Wales and Northern Ireland to take part. We had 127 sites actually contributing data. We invited sites to submit a sample of up to 40 patients from transfusions taking place in a 2-month period in 2024. And we had a full sample of almost 3,000 patients for us to actually analyse in this case. We had a decent chunk of data for us to be able to look at. And if we go on to the next slide, please, we can see some of the key results we found from that audit. Now, looking at the results we've got here, and I've just pulled out the key ones here. This isn't everything we had in the audit process. We can see that a lot of the bits of the process that we looked at are actually being met. What I would say if I was doing a local audit, quite well. At 9 out of 10, 90%, some of these are up to 95%, which you would say is quite a good result in terms of actual compliance with the process. Certainly, I know if I was doing this purely locally instead of a national audit, I would say well, 90% is generally quite good. However, if we go to the next slide and look at this in terms of numbers instead, we actually start to get a slightly different picture. So where we say that, well, only about 5–10% of patients checks weren't conducted at the patient's bedside, because bedside transfusion, because that transfusion process happens so often, that's actually 137 patients who didn't have that bedside transfusion check done at the bedside. That's 450 component packs which weren't visually inspected before the transfusion took place. That's 240 members of staff who didn't ask the patient to properly state their name and date of birth before they actually before transfusing, and that's 350 patients who didn't actually have a post-transfusion check at the end of the transfusion process. So each of these failures, in effect, is a chance for us to do something differently, for us to improve the process, and for us to be able to put the patient at less risk. As we you've thrown me there. I wasn't going on to the next slide yet, but that's fine. If we add all thank you. If we add all those numbers up, then we come to about 2,000 patients. So that's almost for every 3 patients we treat. In effect, we've got 2 instances of something that's done wrong, where we could have in effect done things better, and we could have avoided the risk of harm to the patient. Now, it's not as bad as all that. It's not 2 in every 3 patients. As we saw from the example earlier, what normally happens is that a lot of these things will come together. So where we've got 354 patients not having that end of transfusion check, those are probably overlapping quite a lot with the patients not having 15-minute checks and not having the checks pre-transfusion as well. So it's not actually 2,000 out of 3,000 patients not being treated correctly. It's probably a smaller number than that, but it is a large opportunity for us to improve. And what we did this time around, how we did this differently, was instead of running this as a case note audit, instead of just looking at the case notes and saying, right, well, what do we see, what is in there? This was run as more of an observational interventional workshop approach. So the idea was that our transfusion practitioner who was conducting the audit was going out and collecting this data live. And what that allowed them to do was to observe the process and try and identify where the problems were actually occurring at the point that they were happening. So they were able to identify and feed back to us on what the problems were. And if we go on to the next slide, thank you, we can see where some of those issues were. So we can see that the staff members were able to identify that sometimes the reason that checks weren't always done at the bedside was because equipment wasn't available working at the point where they went down to conduct those checks. So these were sometimes simple things, like, for example, a giving set not being available when a member of staff went to start the transfusion. And the staff member conducting the audit with TP was able to look at that process and identify where those hiccups were and help with rearranging where equipment was, rearranging where that was in the transfusion process, so that things could work more smoothly and they'd be able to do that process correctly in the future. So we had a net positive from the actual process of the audit in that we were able to correct these problems as they actually occurred, as well as understanding where they happened. As well as problems around the process themselves, we also had issues around staff awareness of how the processes should be done. So we had staff members who weren't aware of the requirement or the process or the policy for these things going ahead, or who didn't actually understand why the process was so important of us doing those patient checks before, doing those identification checks before we actually go to the patient and do something about it. Because a member of staff was there, because the TP was actually auditing the process live, they were able to intervene with this, and they were able to do a bit of on-the-spot training, which for a clinical audit is quite a classic form of intervention to try and do something. This patient is staff training, but because they were doing this as the process was ongoing, they were able to identify not only the staff member who required the training, but also specifically which bits of training were needed. So they didn't have to try and do the whole process of training. They could tailor what they were feeding back to exactly what was needed. And the other useful thing they were able to do was to identify to that staff member exactly why it was important that they did that process. So they were able to not only train on what should be done, but also to give an idea of why it was important that it was done for that staff member. So overall, for us, this was a much better audit process in terms of getting an idea not only of what was going wrong, but also in how it was going wrong and what we could do about it, and where the opportunities were for improvement. And this is something we're looking to continue to do. So I know, obviously you've already heard Charlotte put out, I've got various resources that can support you to make these improvements as well. We're looking to launch things ourselves as well to help support those things. And a lot of you will hopefully have received an email yesterday to let you know that we've launched our practitioner homepage as part of the National Comparative Audit website. On there, you'll get access to tools which will allow you to do similar things to what we've done in this audit. So currently on there, there is a clinical audit tool which will enable you to conduct a similar bedside transfusion audit yourself, and includes everything you would need to do a similar process. So it's a tool which will enable you to print off data collection. It will enable you to analyze the data in the tool, and it will do a quick report to allow you to do something very similar to what we've done here, and do that live process of actually going out, finding out what's going on, and making that intervention, that improvement in practice. And the idea is that this is a tool that will help you do that in the space of 24 hours if you need to. The idea is that we will grow that as a resource of information, and slowly there'll be more tools based on the various clinical audits that we do that will be available from that site, along with various forms of guidance and information, which will help you to make further improvements and hopefully use clinical audit as a tool to make those improvements that you require in your practice. Thank you very much. That's the end of my show.
Lovely, thanks, Paul. So we've heard from Shruthi that SHOT have had increasing reports of delays related to transfusion and of associated morbidity and mortality. And a good proportion of those involve bleeding in a major hemorrhage scenario. And that was one of the things that prompted us this year to audit major hemorrhage protocols. So we asked sites to contribute data on ideally at least 10 but up to 40 cases of major hemorrhage over a 3-month period at the start of this year. And this is situations where either the major hemorrhage protocol had been activated or enough blood components were issued to a patient that it was clear that this was a major hemorrhage setting, even if the protocol hadn't been formally activated. And what we were looking at here wasn't the kind of the detailed management of that individual patient, which is something that requires a high degree of kind of tailoring and understanding that individual scenario, but we were looking at how the protocol itself was working, how efficiently. And then we also asked sites some information about how their processes, their protocols were set up in their local area, the sort of training and drills and audits they perform. So these data are still in the final stages of analysis, so you won't have seen the final report yet. That will be coming by the end of the year. So this is hot off the press and some sneak previews. But we managed to audit over 3,700 cases of major hemorrhage, covering 188 sites, and hemorrhage in various different disciplines. And we saw that in 97% of the cases, the MHP was formally activated, though in a significant proportion that wasn't completely in line with the local policy. And common issues that came up were the clinical team not making a separate call to the laboratory to tell them who the patient was, where they were, what components were needed. There were sometimes issues with use of a kind of standard phone line to the laboratory rather than the red phone, or switchboard not passing on communications. And then we did see pretty poor rates of actually bothering to step down the major hemorrhage protocol. So over 40% it wasn't stepped down. And then we asked a kind of general question, were there any issues, problems reported with that particular activation? And 13% of cases, there was some issue either from the laboratory or the clinical area. And the kind of common themes that came up were, as I mentioned, problems with activation, communication, it won't surprise you, was often a challenge. So laboratory being unable to reach the clinical area commonly comes up. Appropriate use of the major hemorrhage protocol, so it being activated just to get a couple of units urgently or to expedite a sample. We saw some issues with taking group and screen samples from patients, issues with information technology, so around access to blood fridges, for example. And then John has already spoken about the challenges with collecting data from notes, and we saw that reflected in terms of how well major hemorrhage is documented in electronic patient records, and so how easy it was for teams to be able to collect and audit this data. So when it comes to use of components in the major hemorrhage setting, it was reflected that there are a high proportion of cases where the MHP was activated, but actually the patient received no transfusion at all. And a lot of those were major obstetric hemorrhage. And that's become part of quite a lot of clinical protocols to proactively activate the MHP if a woman's bled more than 1,500 mils. But interestingly, we saw that reflected from laboratory teams that they weren't necessarily aware of that. And so it wasn't necessarily clear what actions were expected of the lab when a major obstetric hemorrhage was activated. You know, do they go straight ahead and start thawing plasma components, or do they just need to be on alert and ready to act if they're needed? I'm sure you're all aware of the challenges we've had of pressures of O-negative stocks. And interesting, we found here around a third of bleeding males received emergency O-neg rather than potentially receiving emergency O-pos. And we also saw a significant number of cases where issues with group and screen sampling meant that it wasn't possible to issue a patient's own blood group when major hemorrhage continued. We did see over 70% of patients with ongoing bleeding having some sort of clotting tests to guide the use of plasma components. And we also saw over 60% of patients with major bleeding documented as having received tranexamic acid. And obviously a good number more may have received it, but it was hard to find in the notes. Around 2/3 did get TXA within an hour, but there was a notable percent didn't receive it until after 3 hours had passed. And after that sort of time, tranexamic acid ceases to be helpful and can potentially be harmful. So there's probably some improvements to be made there. And it is worth noting that over half of those who didn't receive TXA, or we couldn't find the documentation, did actually have a valid reason not to receive it. So often that related to GI bleeding, for example. The organisational questionnaire, I think, reveals some really interesting insights to get the kind of national picture. So it was really abundantly clear that there were such of a wide variety of methods of activating the major hemorrhage protocol. So many sites use 4.2s, but there were other kind of short codes, different red phones, and sometimes we saw even within a trust that different sites had different activation methods. And a high proportion need a separate call to the laboratory. And often that's avoidable, but it is a challenge for clinical teams and particularly for doctors who do rotate quite frequently. I mentioned that around a third of bleeding males received O-neg, and though 83% of sites said they had a policy to transfuse O-pos to bleeding males, actually of those who use remote blood fridges, only around a third stock the O-pos in the remote blood fridge. So are you really facilitating access to O-pos for your bleeding males? And I thought it was quite interesting also increasing use of point of care testing to guide transfusion therapy in major hemorrhage. But we saw nearly 20% of sites using it, but not actually having a policy for its use and maintenance. And 3/4, the point of care devices don't interface to the LIMS or to the electronic patient record, which means you've got no kind of audit trail of why of the results or why components might have been given. And when it comes to practicing the major hemorrhage process, a high number of sites, 86%, do say that they conduct drills, but 15% less often than once a year, and over a third just once a year, and around a third not involving all of the stakeholders, so laboratory and the clinical areas. So missing an opportunity to really test the process end to end. And when it comes to local audit for your own performance, around 1 in 5 sites not doing any audit of their major hemorrhage activations, and probably about a quarter only managing to do that once a year or less frequently. So a few early recommendations, and keep an eye out for the full report because there may be more. So certainly trying to simplify the activation process as much as possible, and try to at least to harmonise across your sites. And to me, I think it's not enough. So thankfully, major hemorrhage is in most settings is relatively uncommon. But that means that if your staff members cover it once every 2 years in their stat and manned training, that they're going to forget in the meantime. So having some sort of, even if it's annual reminder that goes to all staff of how you set the process in motion, I think would be really valuable. And then when you're designing your major hemorrhage protocol, involve the clinical team as well as the laboratory team. And similarly, when clinical teams make a decision about activating the MHP in prophylactically in major obstetric bleeding, for example, make sure the laboratory knows about that and exactly what action they're expected to take. And then it is recommended, it's in the BSH guidelines, to run drills at least once a year, but really make the use that opportunity to get the most from them. So involve all the stakeholders, and that means the laboratory, the clinical areas, portering, the switchboard. And then if you're only able to do one a year, make sure everyone knows about it. So really share the learning, and do check out that new major hemorrhage toolkit when it comes on the SHOT website, because that's going to help you to run your drills. And as Paul was mentioning, in terms of our audit tool for the bedside audit, we'll now be working on a quick audit tool, which you'll find on the practitioner homepage in due course, for auditing your major hemorrhage locally, which will help you avoid you redesigning from scratch, or produce you an automated printout, so you've got your results in summary, to make it easy for you to follow up on your own practice.
Thanks very much, Kath, John, and Paul. I think we will go on to questions in a minute, but I also wanted to actually end by saying there are several other upcoming educational events from SHOT. We have a Meet the Experts virtual session. This is focusing on hemolytic transfusion reactions, as well as summary report for the hemoglobinopathy patients. And this is going to be next Friday, 14th of November. We are also actually running the human factors and ergonomics principles in transfusion virtual courses. And we will end the year by focusing on learning from excellence and day-to-day events as well. So that is the SHOT ACE, and that would be on 17th of December. And we are on LinkedIn. We are no longer on Twitter, so please do actually connect with us. And these are the other contact details. But now I think it's time for questions. So thanks, everyone.
Thank you very much to all the speakers. We do have some questions in the panel. This is quite a long one, so if you want me to break it down at all, just let me know and I can ask specific bits of it. But there's a question here: based on the data John mentioned on the iron deficient patients, our missed opportunities for iron infusions, I find occasionally when issuing units to chronically transfused patients who are often BM impairment patients, I assume that's bone marrow, I see they are often iron deficient. So the first question is, are these details being recorded in the audit? I wonder how effective iron would be, and if these patients are excluded from that audit as they might not be an appropriate candidate for iron infusion, or should iron infusions be offered in these patients?
Emma, if I can go first and then Kath, ask you to comment on the clinical aspects, because I'm going to talk about how we design these audits, Emma. And so here you give the case selection responsibility to the hospital itself, rather than us define the parameters by which people should collect those patients. In this particular case of NICE QS 138, you should satisfy yourself that the patient is known to be iron deficient and has a condition that is amenable to correction, and it's appropriate to give them iron to correct their hemoglobin, to increase their iron, so that therefore we could avoid the transfusion. So that's why we don't necessarily set down a lot of, oh, you must select this patient, we haven't got exclusion criteria and so on. But Kath, is what Emma said a clinically appropriate situation to use iron?
Yeah, so when it comes to QS 138, it's we're strictly auditing those quality standards. So they refer to patients who are going to undergo surgical procedures, and as John said, are found to be iron deficient. But I think what the questioner has raised is really the key point of clinical audit, is that, and what we're trying to illustrate today is that if you've identified a problem locally or a potential area for quality improvement, then you design your local audit to meet those needs, to demonstrate if there is an unmet need, and then put in an intervention to fix it. So yeah, absolutely, we do find that we may be our patients with chronic transfusion requirements could have an element of iron deficiency. They've been bleeding, you didn't know about it, and if you think that's an issue with you locally, you can design an audit for your regularly transfused patients to review their iron status, and that might lead you to put in some new pathways that make sure that's routinely reviewed, for example, in their clinic appointment.
I hope that answers your question, Zoe. If not, do post another one. And just there's a couple of people who've mentioned that the HTR and hemoglobin, I can't say that today, webinar, the link isn't working. So we're working to correct that in the background. So over to Karen for the next question now, please.
Emma, I have put the link in the response to the chat, so people can
Lovely.
register at that. Thank you.
Okay, great.
Thanks both. Thank you to Kath and John. There's been quite a few questions around patient involvement, etc., around the audit process. And the first question is, what should a patient or a potential patient make of the findings of these audits? I think this question came in when Paul was doing his audit discussion. So Paul, if you'd like to take this question.
But also, I think we really are, grateful to Graham, who is actually here with us. So maybe it's also useful to hear from Graham as the patient representative first, and then we come to the panel.
I was about to pass the buck to Graham, so that works quite well. No, I think as a patient, I'm probably the wrong person to ask about this, because obviously I know about how the clinical audit process works. As a patient, I would be happy that a topic is being taken up on clinical audit. I think I would be concerned about the fact, I'd be more concerned about an audit such as the one that John's described, where it's been going on for a long time and supposedly nothing has happened about it. But I would certainly be happy to know that subject was raised enough to be addressed. I think Graham is perhaps a better place to give us a view as a patient.
I think Graham had some IT issues, so it looks like he may join us, and maybe we hold on to this towards the end. But yeah, I think Kath can also come in. I think as a as a clinician, I think we should endeavour to involve the patients at various aspects, not just in their aspects of their individual care, but also with respect to the organizational safety and the audits. And I think various people may have done that in different ways as well, whether actively in the when you're devising the audit questionnaire, or getting the feedback from the patients about what it meant for their care, or also in hospital transfusion committees as well, where they are actually then they can provide and inform the recommendations that would be actually coming following the audits as well. But Kath, you may want to come in.
Yeah, and it is was a specific recommendation in the infected blood inquiry around involving patients in clinical audit, and it's great for us because it means your trust will be aware of that and ready to hear. Because one of the things I think we found very powerful is having that patient voice, that patient perspective, and that really does that rings true with your senior exec when you have a patient saying, I'm shocked by this, I'm encouraged by this. It really does, it helps to pull strings, and it helps to change something that is numbers into actual patient impact. And we have a patient representative working with one of our other upcoming audits. And one of the first things that she actually said was, well, what happened to these patients who didn't meet the standards? And I think we sometimes get a bit blind when we're doing clinical audits, and we cite a load of numbers, but actually each one of these is a person, and that's one of the things that your patient rep will really highlight, and it reminds us of why we're doing it and what it's all about. So I think if you're doing your local audits, see if you can tap into your hospital will have a kind of a patient group. You may have a group of volunteers. See if you can enlist someone to help you with your audit, whether that's looking at what would a patient want me to check in this or to be looking at in this scenario, or what do I make of the results, and ask them just to write a few words and then present those along with your numbers to your senior leaders, and I think it will really help strengthen our voice when we're asking for their support and senior buy-in.
Shruthi, if I can just build on what Kath said, one of the problems if you're doing this locally as well as we're doing it nationally, in terms of looking at it from the patient's point of view, if they're not being treated as they might expect or we might expect, the first question they're going to ask is why? Why am I not being treated this way? And one of the things with clinical audit we have, which we're changing, and I'll tell you a bit about that, is that it's easy to collect such limited information as might be available, but that tells you what's going on. What you often don't know is why what is going on. So if you're going to do an audit locally, as Kath rightly suggests, try to extend that. Now, SHOT's got a webinar coming up later on this year looking at human factors approach. And the human factors approach really looks into what is it that makes that person not do what we expect. I won't go into it in depth, but it talks about the healthcare professional doesn't know what to do, or for some reason does something different, or the system that you have to work in doesn't allow them to do it properly. If you're going to do a local audit, then try to find out why something happened and what can be done about it. Paul spoke to you earlier on about that spreadsheet we put around on the practitioner homepage. That allows you to go further by saying, oh, I see that wasn't done, help me understand why. And once you know why, you can then put an intervention in to try and make a difference. Because just counting the beans is no longer good enough. We need to find out why the beans are why they are, Shruthi.
Thanks very much, John. Shall I move on to the next question? Is that okay? So we've got this question from Luke Dowie for QS 138. Do you have any plans to include patients' transfused platelets to audit against QS 3, 4 and 5? Around 40% of our annual transfusions are platelets, so we could supply more data if platelets are included. There is a second bit to that question. Do you want to answer the first bit first, or you want me to carry on?
Let's do the first one. Again,
Okay.
I'll come back to Kath after this, if I may. Thanks, Emma. So, Luke, no, not immediately, but what we will be doing in the autumn of next year is quite a large platelet audit, looking at platelet transfusions in detail. But, Kath, I'm right in thinking we're not really going to extend QS 138 to other components, are we?
No, so QS 138 is QS 138, and the NICE quality standards refers only to red cells. What I will say is many people might be aware that NICE are working on updating their blood transfusion guidance. It's not a quick process, but the will be agile and respond to kind of the quality standards themselves may change focus. But we are one vehicle to help kind of collect this data in a medium to longer term forward look as part of national benchmarking, which is recommended under the infected blood inquiry. So we are likely to continue doing this in some sort of format. Exactly what we're collecting and how will be agile and change over time in response to the kind of NICE's guidance and the national needs.
Okay, thank you. And the second bit of that question was, additionally for QS 138 statement 3, are outpatients excluded as they typically don't return within 24 hours for repeat FBC clinical review, but this does occur either 36, 48 or 72 hours, but almost always before further blood products are given. Could the audit be expanded to consider, if not within 24 hours, when does the reassessment occur?
I'm going to pass that one to Kath, Emma. So I guess, Kath, the whole idea of the 24 hours is because you need to make sure that A, the patient is benefiting from the transfusion, or the patient isn't suffering as a result of the transfusion. And 24 hours, I guess, might well be the time in which those things are manifested. But what about Luke's point then? Is there any value in extending that?
What I'd say is it's probably relatively uncommon for a patient with acute anemia, which is what this standard refers to. So that is generally someone who's had a sudden hemoglobin drop over days to short weeks. So it's often in the post-surgical setting. So someone who's had a bleeding event and has now stopped bleeding, and just needs a kind of a temporary, a transfusion to tide them through until they're recovering. It's fairly infrequent that that sort of patient would be managed in an outpatient setting. So your anemic outpatient is more likely either to be someone with a long-term transfusion requirement who might be transfusion dependent, and those thresholds in the single unit doesn't necessarily apply, or there'd be someone with a kind of a chronic anemia where you're going to be looking to fix the underlying cause, often like hemotinics, in which case the new MBTC indication code makes it very clear you should only be giving, the minimum volume. You should be giving a single unit, if that, while you fix the underlying problem. So your outpatients are probably don't kind of neatly fit into the type of patient we're trying to audit in QS 138.
Thank you very much, both. And I think Graham has managed to join us again. So if we can go back to Graham. Can you hear us okay, Graham?
Yeah, I can hear you fine. I've been able to hear you all the time. What seemed to happen was that I got turned off.
Oh, sorry about that, Graham.
No,
There are two.
Well, I'm sure it wasn't deliberate. But,
no, it wasn't. No.
I did seem to. And really, the discussion has moved on a bit from, I think, the question I was going to answer with how would a patient react to all this? And I mean, as regards QS 138, I actually wrote a little foreword to that, and that to some extent summarizes, I think, how I feel about where we are now. So I think they'd be a bit discouraged and a bit disappointed, because just looking at it from an ordinary common sense point of view, we've got standards, however outdated, which have been in effect for a good number of years, and yet things don't seem to be, after things started to improve, they're now static. But we could regard all this as a challenge and an opportunity, and just not just something to wring our hands about. In that we've got the infected blood inquiry and everything that flows from that. We've got the SHOT report also showing, sadly, that in some respects things aren't going in the right direction. And then we have QS 138, which shows the same. So in a way, that's a pressure to not to sort of lament, but a pressure to improve. And that's an encouragement if that can all be mobilized, because we have to keep remembering this is all that we've been talking about is intended to benefit patients, some of them very sick indeed, and to make them well. And if I'm in hospital, that's my prime interest is getting home again in one piece and not feet first.
Okay, thank you very much. Unfortunately, we're almost out of time, but thank you for all those great questions, and apologies we've not quite been able to answer all of them during the session, but if you do have any burning questions, please send them through to us at the SHOT email address, which is shot@nhsbt.nhs.uk, and we'll try our very best to answer them. Likewise, if you're watching this on a recording and you think of any questions, then please do send them through to us as well.